Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Rachel Frank, a sports and shoulder surgeon at the University of Colorado in Denver. Rachel, how are you?
I'm doing great, Pete. How are you today?
Oh, everything's good. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, the University of Colorado, or the institutions of any of our guests. Okay, so today we have an episode for you on a problem in shoulder surgery that we're still working to solve, which is the evaluation and management of acromial stress fractures after a reverse total shoulder arthroplasty. We've invited two experts to provide their insight. First, we have Dr. Larry Gulotta of the Hospital for Obstetric Surgery in New York City. Larry, welcome to the podcast.
Thank you, Pete. Thank you, Rachel. Happy to be here.
And second, we have Dr. Steve Parada, who's at the Medical College of Georgia in Augusta. Steve, welcome to the podcast.
Thank you guys very much. Thanks for the invite.
All right, so let's just start at the beginning with the etiology. Now, Larry, you've done a bunch of biomechanical and computer simulation work in this area. Tell us, what do you think are the main factors that contribute to this problem?
Yeah, so it's a good question. I think we're still figuring that out. But in the lab, I think one thing that we've gotten caught up on the lab, which I think was misguided, is the tension by which we put the replacements in. Because in the lab, all we can do is really test a cadaver and see how tight we're putting them in and what sort of forces that then translates onto the acromion. But I'll tell you, I'm curious to see what you guys think about it. But in my clinical practice, I find this to be more of a dynamic problem. In fact, actually, the shoulders I put in a little tight that are stiff, those don't seem to be the ones that get acromial stress fractures. Rather, it's the patients who have a little bit more flexibility. They get their motion back very quickly. And then I think what ends up happening is that it's a dynamic pull of the deltoid on the acromion that ends up causing this stress fracture. So if you ask sort of what the classic setup for a patient is, it happens to be a female more than men, happens to be patients with osteoporosis, it happens to be patients that have cuff tear arthropathy, so there's really no cuff there at all, and so they're really dependent on that deltoid postoperatively. And then it's the patients that were pretty debilitated beforehand. I mean, these are patients that haven't lifted up their arm for maybe years before they end up having their shoulder replacement, and then they show up at 3 months and they can do everything sort of all at once. And those are the patients that I'm really concerned about that seem to be at high risk, and that's a lot of what the clinical data would show as well.
I love the way you laid it out, almost as like a mismatch between a deltoid strength and, acromial ability to resist that strength. I wanted to follow up with you with one specific thing you guys did with the coracoacromial ligament. Now, I've read this paper several times, and I still have trouble wrapping my head around how cutting the CA ligament increases the strain. Tell us about that.
Yeah, this is actually an idea of one of my partners, Sam Taylor. I think it was a great idea. And his thought was that ligament is there. We don't respect it very much. Every acromioplasty we do, we take it down. And a lot of shoulder replacement surgeons will take it down as well. But it's a pretty robust ligament, and therefore it must be seeing some load somewhere along the way. And we found that in the laboratory, when you cut that ligament, the stress ends up concentrating right at the scapular spine. So it doesn't necessarily increase the overall stress on the acromion itself. It just concentrates it all at the scapular spine. So the thought is that potentially cutting the CA ligament at the time of reverse shoulder replacement might be a modifiable risk factor for preventing at least the scapular spine stress fracture. Now that's in the biomechanics. We've yet to be able to parse that out in a clinical study, but these are relatively rare instances. And I think it'll take a long time for us to have a definitive answer to that.
Now, Steve, tell us your thoughts. What do you think causes the problem? Are you cutting the CA ligament? Do you think that's part of the problem?
No, I think that's a really interesting point, because I think, we cut the CA ligament so often in other cases, and without any seemingly compromise that ever happens. And so I think it's interesting. So I don't routinely cut it, but I don't have any problem with cutting it if I felt like that was affecting my visibility or my glenoid exposure. And so I think, obviously all the things that like Larry talked about, and then I think the scapular morphology is something that, we are trying to, pay more and more attention to, because we feel like a lot of these patients are probably set up for their underlying pathology from the get-go. as far as, where their acromion is and whether or not they, with the critical shoulder angle, whether they go on to get cuff arthropathy or arthritis. And so I think their underlying reason of why you're doing a reverse probably matters. And I think we've all seen those patients who just have a wafer thin acromion because they've been riding so high for so long and they have so much acromial wear. And those are the ones that I always get, obviously very nervous about. But to be fair, I've never actually had one of those that goes on to get either a stress fracture or a completed fracture. And so the same with the patients with an OS. And so we see these patients that have an OS and we wonder, about them, especially based on the morphology of the OS. But again, those aren't the patients that I'm seeing get these stress reactions or fractures afterwards. I don't know, Larry, what your thoughts are on that.
No, I agree with you. We looked up a bunch of patients and we called it a quote unquote compromised acromion. Either it had some fragmentation or they had an os acromiale or it's just extraordinarily thin. And those are not the ones, to your point, that get into trouble. And in fact, that goes back to a time I visited Gilles Walsh in Lyon, France. He said that too. He says, "Oh, you don't have to worry about that," which seemed a bit cavalier, but I think he has more experience, or had at the time more experience than anybody. And so I think that was saying something. I do think it's about this increased function that happens in a relatively short period of time. I mean, this is a stress fracture. And so, I mean, Steve, when military cadets march, they get second metatarsal fractures, or people ramp up their training for marathons, they get tibial stress fractures or femoral neck stress fracture. And I think that's what's happening with the shoulder here, is when they go from 0 to 60 in a relatively short period of time, then they're set up for these fractures. And obviously the osteoporosis and other things can contribute to it as well. But it's almost like it's a byproduct of, quite frankly, how good and how miraculous this procedure can be for certain patients.
Yeah, I think that's a great point. And I think we try to, from looking at these so much, that patient that you described, kind of that high risk, elderly female, inflammatory arthritis, osteoporosis, all those pre-existing factors, we kind of talk to them and say, we try to head it off in the past by saying, like, listen, in your post-op, period, if you're getting any soreness on top, not like, muscle strain like some of them get, but actual that pinpoint acromial soreness, like if you get any of that, then we're kind of shutting you down, and we're taking a step away from therapy for a few weeks, and we're really going to slow things down. And we counsel our patients, those at-risk patients, on that ahead of time, because like you said, they feel so good. It's otherwise hard to keep them in their sling. I mean, they're feeling good, and they're using the shoulder for the first time in years, sometimes, more than a decade. They want to use their shoulder. And so I think it is really hard to slow them down.
Yeah, I think you make a really good point there, Steve. And I've noticed that too, that a lot of these have some sort of like prodromal symptoms or so. I've had a couple patients where it's been very acute. Obviously, there's a subset of patients that do have traumas. They fall and they can break their acromion, and that's been a rare group of patients, I'd say. But most patients, for me, it's almost always, it's really that 3 to 6 month point. They're doing phenomenal, and then they start to get some achiness on the top of the shoulder. And I just like you, it's, the first part of that follow-up visit, at least when they're doing well, is, listen, I'm so glad that you're doing well, but now, you're doing physical therapy, you're using your arm, you're changing every light bulb in the house, you're dusting every top shelf in the house that hasn't been dusted for years. You're doing more with your shoulder than I'm doing with my shoulder, and I did not have a reverse shoulder replacement within the past year or so. So we need to calm it down. And for me, even a lot of those patients, I've been quick to take them out of physical therapy. A lot of our New York patients really feel like they have to do physical therapy, and they're going to be in physical therapy for months and months. They love doing it for some reason. But that 3-month patient who's doing really, really well, I'll tell them, hey, listen, I don't think you need to do physical therapy anymore. I think just using your shoulder is all you need to do. And God forbid you start to get any pain on the top of the shoulder, you got to call me right away, and we got to shut you down and nip that in the bud before it becomes a bigger problem.
Yeah, same. I think completely same. And I think, we can obviously go into diagnosis. When we looked at a bunch of pooled data, we found that up to a fifth of these, end up never being visible on X-ray. And obviously you have a lot of overlapping metal in the views that can be tough to see. But I don't even really, for me, the further imaging is rarely, something that we need to do, because we are, just like you said, if patients get these symptoms, then we're slowing everything down. We're putting them back in a sling, or we put them in a huge abduction pillow to really relax the tension. And we tell them take a hard pause, physical therapy. We see them back to 4 to 6 weeks, and we don't restart anything until they're symptom free. And again, a lot of those, I think that probably happens. And it's hard to make an official diagnosis of whether that's a stress reaction or a stress fracture. And so the number, when we looked at a lot of these different series and the number gets up to, 10, 11%, it's probably how, just really how aggressively they're going after getting that diagnosis. And so a lot of times I think the lower, couple percent that we see more often in series probably isn't including those patients that just get that superior shoulder pain, and we're slowing them down because then they get better and it doesn't go on to be, a big problem with their rehab. And I saw a lady today, she's 1 year post-op, and she had, she was the exact patient that we're describing, and we slowed her down and she did great. And her numbers, she's had bilateral reverses. And so when I look at her numbers that we took today, the one side versus the other, as far as where her range of motion and her strength and everything like that, she didn't, she did fine. And that's what we expect. We expect them to go on and still be able to, these patients that don't go on to a complete fracture, we expect them to go on and still get, just do just as well as our other patients. And so that's always great when we're able to see that.
Yeah, I agree with you. I think it could be really devastating for patients because, again, they're flying and then they have this setback and they really think, oh boy, I'm back to square one again. And I mean, that is the conversation. You got to pull up your chair and spend some time in there talking to the patient and tell them, listen, we get an X-ray. I don't see anything. There's no mechanical complication. I don't see any obviously displaced fractures. I think you're getting the stress reaction / deltoid tendonitis / very early acromial stress fracture, whatever part of the spectrum of the pathology you want to put them on. I think is more just semantics, to your point. But we got to shut it down now. And I don't see any signs of an infection on your skin, or at least no overt signs of it. So anything that's scary, I'm not seeing that's happening. And this is something that we do see. It's relatively common. If you're going to run into a problem, this is one of the more common problems you're going to run into. And I call it an obstacle, not a complication at this point, and saying we'll get over the obstacle, but you are going to have to shut it down. So.
We'd like to ask you guys, do you think that there are implant-related factors at play here? Are there certain implant geometries that are more prone to this problem than others? Steve, let's start with you. Any thoughts on this?
Yeah, I mean, I think, calling this a deltoid tension problem, then we think that implants that are distalizing and inferiorizing, more is obviously going to, at least we would suspect if we're doing that in the lab, that's going to lead to more of a problem. I think, most of the time, if we're just kind of lateralizing on the glenoid side, to make up for, bone loss and medialization, then I think, technically you're using, lateralizing through the base plate or lateralizing through the glenosphere, but you're just kind of making up for their wear pattern. So I don't think that's as big of a deal. And so I think, luckily, this is a small enough problem that it's hard to study clinically. So when we do these biomechanical studies, it just kind of is looking at the biomechanical studies, it's just more kind of like the obvious things like, well, the more we put the deltoid on stretch, probably the more we affect this. And so implants that do that will probably have a higher rate in the lab. I'm not sure that translates clinically.
Yeah, I actually think because we went down that route a lot. We looked at X-rays and we looked for distalization, for medialization. We looked for signs, and then we looked at it in the lab too. So how tight can we put these in, and do we start to run into trouble? And I really don't think that the time zero tightness, the distalization that you put in, really ends up affecting this whatsoever. It doesn't seem to affect it clinically. It doesn't necessarily affect it in the laboratory when we look at it. So to my kind of back where I started with this, I think this is a dynamic problem. Now, I'm going to say the short answer and the official answer to your question, Rachel, that I'm going to stick with is that I don't know. and I'm not making any hard and fast decisions or proclamations here. But, I will say, if you look at some of the systematic reviews, it would show an implant design with a lateral center of rotation on the glenoid and a medialized humerus does put you at higher risk. Now, I think, though, that the people who have reported on that type of an implant, like John Levy and Mark Frankel, for example, are extraordinarily honest reporters that are probably including more of those patients with the quote unquote stress reaction that Steve talked about. So I don't think that in and of itself is proof that that type of design puts you at risk. That being said, if you do start to look at free body diagrams, that type of design does start to decrease the moment arm that the deltoid works. And therefore, the deltoid does have to create more force because it has less torque. It has a lower moment arm. It needs to create more force to achieve the same amount of rotation, to go back to high school physics. And so I think from a theoretical standpoint, there could be some hand-waving explanations. But I would say, again, the short answer to it, that's kind of just a geek out session right there. I don't know is the short answer.
It's interesting. We showed the same thing in our own lab, that what you said about lateralized center rotation with medialized humerus, that really puts the deltoid at more of a relative disadvantage and requires greater force in the deltoid to create the same amount of motion. But I totally agree with you that it's probably not that simple, because that's one among a multitude of factors. There's other factors people talk about. Like, we had John Levy on our podcast, and he had like CTs of 50 of these that he'd had, and I think he's particularly interested in this problem, so he's collecting them. But he mentioned that he thinks that some of them are impingement related. There's also people who talk about this being related to base plate screw positioning, that if you get your screw in the wrong spot, then maybe that's the source of a lot of them. Do you think these other alternative explanations play a role in some cases? I mean, are each of these fractures different depending on where they occur? What do you think, Steve?
I think it's interesting. I think one of the things that, preoperative planning, understanding of, all the different systems that are out now that are letting us have intraoperative kind of guidance, either with a CT navigation or augmented reality. I think we're all getting a better understanding of scapular morphology, from that view of the glenoid that we get. And so I think it makes sense to me, if you are trying to get that superior screw and you've got a drill and you're kind of going over and over and over again, just trying to kind of guess, find a column of bone, that multiple passes with that drill could lead to a stress riser there. I think, Dr. Crosby's data, my predecessor, was kind of blamed that superior screw. The numbers were overall pretty small. There were, only looking at 100 patients in one group, a couple hundred in the other group. So, those kind of numbers, those statistics can really get skewed with just a couple findings one way or the other. We haven't seen that data kind of continue forward, but I think it's because of our understanding of the anatomy a little bit better. Now, when we're putting that superior screw in, we're using whatever technique that you use. I think that's in bone, and so I think the screw itself probably was not responsible for a stress riser. I think it was just multiple passes, and I think again the planning these cases, looking at the scapular morphology more, I think you can avoid that now, and so I think you can feel comfortable putting a superior screw in whenever you think that you need that.
Yeah, I talked to John about this a lot, and I would say that at least my patients, when I'm trialing patients intraoperatively, I'm not noticing significant impingement of the acromion on the greater tuberosity, and I am looking for that. Every now and then you will see a patient that starts to engage at about 50 degrees or 45 degrees, and then that's a patient that I am going to adjust either my implants or maybe do a little tuberoplasty, but I'm doing that more for just postoperative range of motion than concerned that they're going to ultimately end up with a stress fracture. But again, John's thought about this a lot, and he feels pretty strongly about it. And I've had these conversations with him, and I'm not entirely sold. I think the superior screw is an interesting one. I think, I would say we all probably have some devastating, or at least an X-ray of a fracture propagate from the tip of that superior screw, go through the scapular spine, which, as we all know, are really the bad actors here. And it's scary. And I think there may be something to it. I don't put, if I'm using a system that allows you to put a 12 o'clock or something maybe even just slightly posterior to that, a screw. I do that unicortically, and I do it unicortically for two reasons. One is because I don't want that to go right to the base of the spine of the scapula, and the other two is I think another sort of underreported issue with reverses can be if that screw goes right through the spinal glenoid notch and bags the suprascapular nerve. I've had patients I think that have come back and seen patients that have some pain and some excessive weakness that they've had. Now, I'll tell you, a lot of times it does get better, but that's just something I'm trying to avoid by a unicortical screw in that location.
That's super interesting about the suprascapular nerve thing. I think that's something that probably sees us more than we see it. So we mentioned a little bit about all of Levy's work. Probably the most important contribution he's made is with the classification scheme. So tell me, Larry, are you using this classification scheme clinically? Is it helpful to you in deciding what to do?
Yeah, it is. I think 1 and 2, I'd probably lump into the similar categories because 1 and 2 are the ones that, I don't want to see, but I do think that we got a shot at getting these patients through it non-operatively. It's the type 3s, the ones that are way posterior at the really scapular spine fractures. Those are bad actors. And those are ones that I've learned from John. I'll be honest with you, I've never fixed one myself. But I do think based on the work that John has done, the next time I see one acutely, I think it makes some sense to try to fix it acutely. Because I think one of the problems we've run into in the past is that we have waited for these to go on the non-unions, and we know that the bone is bad to begin with, and then you're trying to deal with the non-union, and that's part of the reason probably why we've had not so great outcomes with fixing those historically. But I also know that if you let it go on to a non-union, it's kind of game over for that patient. And so I think it's probably worth a shot at trying to salvage that shoulder by fixing it. But the 1s and 2s, my algorithm right now would be to continue to treat those non-operatively.
I'll tell you anecdotally, I've had a couple patients, I'm sure like all of us, right? You see your own complications and then you see everybody's complications, regionally. And so, I've seen a handful of these where everything with the surgery looks like it was done great. And then they develop a scapular spine fracture, and they're usually exactly that high-risk patient. And I've had some patients that are just adamant about not wanting another surgery. And so we've just kind of watched them through this non-operatively. We've used a bone stimulator. We've used these big, abduction pillow braces. Where it looks like they have a rolled up sleeping bag under their arm just to really try to offload that. And we've seen these patients become completely asymptomatic. And I think the literature is pretty damning on these fractures that they will just always do miserable. I mean, there's some data that says they'll have worse scores than they had preoperatively. And it's just interesting to see. And I had one of my own patients come in this last week. And for a 1-year follow-up, and we're getting her subjective data, and she's like 90% shoulder. I'm doing great. I don't have any pain. And oh, by the way, I noticed I have more motion now than I did at the 6-month follow-up. And we get an x-ray, and she's got a scapular spine fracture and completely asymptomatic from it. Blew me away. She's had multiple C-spine surgeries done as well. And so I called my spine buddies and said, is this like Charcot shoulder? Like, what's going on? This lady's completely asymptomatic from that. But that was really unusual. And honestly, I got to be honest, Pete, Rachel, I felt like you guys just jinxed me by inviting me on this podcast, and that's what led to it. But I'm not entirely sure how to explain that.
So, Steve, what would you put? Is that kind of justification or rationale for trying to see those out? You're not being aggressive with operating on the type 3s and seeing if they could potentially go on to heal? What do you do with the type 3? How aggressive are you?
Yeah, I mean, I've fixed those in the past, but when I've seen those chronically, way more than I've seen it acutely, just because it's so rare. And so chronically, what I've done is I've converted it to a hemiarthroplasty. So I've converted it to a hemiarthroplasty and then fixed it and used bone graft, plated it and used bone graft. And my thought was, at least converting it to a hemiarthroplasty, I'm removing the deforming force, which is the constant pull of the deltoid. And so, but honestly, the results are pretty, pretty disappointing. I've done that twice, and I've not been blown away by either one of those cases. Those were both chronic, like years out. And so, Professor Gerber has a paper that is kind of just, online at JSES, kind of comparing operative versus non-operative treatment for these, and didn't find a difference with their final outcomes or the subjective outcomes for this. And so, I think it's very unclear right now what to do. But I think in lieu of poor, or kind of underwhelming data of operatively treated, and then my own anecdotal, evidence of kind of just seeing a couple of these do very well non-operatively, I think I'm going to be kind of hard pressed to operate on these in the future. Patient selection is clearly important, and maybe we just don't have that figured out yet.
Mm-hmm.
Steve, when you do fix these, or when you have fixed these, how do you fix them? What kind of plates do you use? Where do you put the plates? Do you use anything other than plates? What do you do?
Yeah, so that column of bone, if you look at your saw bones, that column of bone is not great, but a plate on the spine biomechanically is what's going to kind of resist this the most. You can get a smaller plate, but that's like a 2-0 plate, kind of just above the spine by peeling off the supra, which is in these patients non-existent anyway. And so I add bone graft. These are elderly patients. I'm not convinced that autograft bone is really a huge advantage over allograft, and so I've just used allograft bone for this and demineralized bone matrix, trying to add some biology just because these are chronic. And then, like I said, I think controversial, but in my mind, converting the reverse to a hemiarthroplasty at least makes sense to me in my head. That at this point, function is kind of out of the window anyway, and we're going for pain, trying to get the pain control, trying to get the fracture to heal. And so in my mind, even if I decrease their function, if I could help them with their pain, that's kind of what I'm thinking. And then I try to use a bone stimulator postoperatively as well. I think it's so hard to have that, kind of data-driven plan or an algorithm for this, just because it's so rare. And so I just try to do what's commonsensical.
Steve, have you converted those hemis back to reverses once you felt like you got the scaphoid spine fracture to heal?
I haven't. No. At that point, again, my N is 2. And so at that point, they were like, okay, hey, I feel a little bit better. I'm super surgeried out at this point. And so, again, I think at that point the expectations have kind of been lowered so much that as soon as they're at all happy, nobody's begging me to convert them back to a reverse.
Yeah, that makes sense. No doubt.
What are your thoughts? Is that overkill? Is that changing anything? Should I just my thought is trying to plate it as it is with this thing kind of, flex down like it is. I'm not sure that fixing it without doing anything else would be worth the shot. The bone is so miserable.
Yeah. Yeah, I mean, I think that definitely it gives you the best shot to get union, and then I guess once you get union, you do have the option to potentially convert it back to reverse if the patient still wants another crack at it. So I think that probably gives you your best shot to fight another day. I've heard Joaquim Sanchez say the same thing, that he has not been able to get them to heal without uncoupling the reverse in some capacity. But then you have others out like John, for example, and Peter or Rachel. I'm not sure what your experience has been with getting to heal, but they don't uncouple it. They repair it. They do 90-90 plating and put, John will put infuse in, and he's starting to get some decent results. It's sort of interesting because I think his argument is that, right, we need to be even more aggressive with these, but it's always because if we get to them acutely, then we have the best shot at getting it to heal. And part of the problem with why there's bad results in the literature is because a lot of those, again, have gone on to non-union, the chronic scenarios. And so, but it's always a little hard to say, hey, we got a surgery that's not great, and how we're going to make it better. Well, we need to do more of it, and we need to be more aggressive with doing it. So
right.
It's a little bit of a leap of faith, but maybe there's something there. Pete, Rachel, what do you guys think about fixing these? What's your experience been?
Yeah, I've fixed a couple of them now, and I personally think the indications for fixing them are when there's a patient who's doing well, and then there's a scapular spine fracture. So the Levy type 3, you mentioned, that's the bad actor. And then the patient can no longer raise their arm after a period of non-op treatment, or that all of a sudden the reverse is unstable. And I've definitely seen that. Or all of a sudden you lose that tension, and then the patient no longer has stability within the construct. But I'm with you that, and this is what I was so curious to hear you guys' thoughts, that I do think there are patients that can do well with these fractures, and I've seen that. So I have trouble predicting who's going to be the patient who does well and who's going to be the patient who still can't raise their arm 3 months later. And now I'm going to say, I wish I'd fixed this 3 months ago. So I'm curious to hear your guys' thoughts. What does the future hold? Are we going to be able to predict in the future who the real bad actors here on these fractures? What do you think, Larry? What do you think the next steps are for
Yeah,
this injury?
yeah, it's a great question. I mean, I'm pessimistic as to our ability to definitively identify who's going to do well and not do well with operative versus non-operative treatment of a scapular spine fracture. And I think, as Steve has said this before, I mean, the numbers are so low, it'll probably take us a lifetime to get enough data points to be able to definitively say one way or another. So I think the real key is going to be to try to prevent it in the first place. And my hopes are, with preoperative planning, we will get to a point where we start to have enough data points for a certain body habitus, a scapular morphology, list of comorbidities such as osteoporosis or vitamin D levels or so, and then be able to, in real or virtually beforehand, be able to simulate what that surgery is going to look like and what sort of forces are we going to subject onto the acromion, and be able to adjust our implant decision and implantation accordingly. That, I do think, would probably is a reasonable solution within our lifetime, and probably the only thing that's going to start to move the needle on this.
What do you think, Steve? I know you're a deep thinker in this area. What's the next step?
No, I think that's it too. I think I agree with everything Larry said, and then I think the other thing is this kind of this understanding that really, that we look at the scapula and we just say, boy, that's a goofy shaped bone, and we say, boy, these look really different, when we're looking at big groups of them, or if we're doing cadaveric studies, when we're doing the biomechanical things and looking at saw bones, it's easy to think that these are all the same. And then you do these cadaveric studies and you're just blown away by the variability of this bone. And so I think, we'll get to the point where the morphology is better understood and the classifications will be broken down by the scapular, the underlying morphology, and we'll input somebody's CT scan, and, somebody like yourself and Rachel will have done all the heavy lifting, and it'll, tell us, like, this is a Chalmers and Frank type 7 scapula. They're going to be in our highest risk group for, post-op fracture based off their morphology. And so maybe we'll adjust their rehab differently. Maybe we'll, treat them with, we'll make sure they're on osteoporosis treatment, things like that, treat them like our fragility fracture patients, things like that. And that's how we'll adjust this a little bit. And we'll have identified other patients that are just in such a low risk group that probably nothing that we do matters, and we can just go about surgery, as usual for them.
Steve, if I ever make a classifications team that has 7 categories, I need you to call me and tell me I need to collapse the categories. Nobody can remember that many categories.
That's a type 7 out of 32. It's going to go deep. Go deep with it.
There's some like resident right out there who's groaning, like, please no, don't do it.
What's the Chalmers and Frank 23 again? Yeah, it's going to be tough.
But so if I can geek out a little more here and talk some science fiction or so, but I really think within our careers, we're going to get rid of a lot of these classification systems, and we are going to use the machine learning to be able to identify risk factors that the human eye just probably isn't going to be able to comprehend. I mean, our inter and intra observer reliability is poor for a lot of these classification systems anyways. And then when you put on maybe 20 different factors that may all contribute varying degrees to something relatively rare like a stress fracture, I just don't, I think now every major industry, every system as some form of 3D planning software. There's a lot of CAT scans being done. There's a lot of CAT scans being uploaded into these databases. And I think at some point we're going to be able to get some machine learning that's going to be able to start to answer these questions for us. Because I don't think we're going to be able to chip away at it one at a time. It's going to take too long, unfortunately.
For sure.
I can't wait until Skynet tells me about my next acromial fracture. You guys were awesome. I can't tell you I appreciate it. Are you guys friends? Like, I didn't know that you guys were going to play off each other so well. You have just like a great repartee. It was amazing. I really appreciate you guys coming on.
Larry is my guy. Are you kidding me? That's my guy.
Way back. Yeah.
You're a perfect
International
duo.
Congress, shoulder and elbow. Again, we'll run it back this year.
Absolutely.
Yeah.
Thank you guys both for coming on. This is amazing.
Great.
Thank you guys so
Thank
much
you for having us.
Me.
Great job putting this program together. It's been a lot of fun for us to participate, and we enjoy listening to them as well. So kudos to you too. Great work.
Well, thank you both so much. And Pete, I just want to clarify, everyone in the ASES is friends, including Steve and Larry. So we're all best friends. But I agree with Pete. You guys were phenomenal and one of the best dynamic duos we've had. So thank you both for being on. That is all the time we have for today's podcast. Again, we want to thank our guests so much for donating their time to us and to the ASES listeners. And for all of our shoulder and elbow listeners out there, please don't forget to subscribe. And for Pete Chalmers, I'm Rachel Frank, and we'll see you next time.